All right, so uh, systolic, um, just like the left side, the RV has a systolic and a diastolic function. Um, we're going to look at the RV diastolic dysfunction today. We already looked at RV systolic uh, function and dysfunction. Remember, the things that we use to assess RV systolic function is TAPSE, tricuspid annular plane systolic excursion, and that is looking at the tricuspid annular plane, how much it is displaced in systole. Okay. Fractional area change, that's another method of evaluating RV systolic function. We talk about RV S prime, that is the tissue Doppler velocity of the lateral tricuspid annular plane. Uh, so those, and then we talk about RIMP, right ventricular index of myocardial performance. So those are some of the parameters that we use to evaluate. Those are some of the parameters we use to evaluate RV systolic function. But you can also evaluate RV diastolic dysfunction. And what we're going to look at, just like the left side, we're going to look at a pulse Doppler across the tricuspid valve. So that we talk about the tricuspid inflow. So it's a pulse wave Doppler, and we're looking at the tricuspid inflow. And just like the left side, you're going to have an E velocity and an A velocity. We're also going to look at the tissue Doppler of the lateral tricuspid annulus. Um, that is, we can look at S prime, and we can also look at E prime and A prime, because just like the mitral annulus, you have when we do tissue Doppler, you have a systolic displacement and diastolic displacement. And remember, when we look at the left side, the diastolic displacement, we have the early diastolic displacement, which is E prime, and then late diastolic displacement, which is A prime. Uh, on the left side, we look at the pulmonary veins, but on the right side, when you're talking about uh, evaluating right side, you have to look at the hepatic vein. Look at the hepatic vein. You can also look at the IVC and its collapsibility, because they remember the hepatic vein drains into the IVC, inferior vena cava, and depending on what's going on the right side, it will determine how well the inferior vena cava collapse with inspiration. Remember, the normal IVC, inferior vena cava, should collapse more than 50% with inspiration or with the sniff test. Um, and when we evaluate these parameters, we look at end expiration during quiet breathing. So the patient is breathing in and out. So after they blow out a breath, you tell them to hold it. Okay, so end expiration. And you should evaluate more than 5 consecutive beats, that 5 beats in a row. Um, However, if the patient is if the patient has significant tricuspid regurgitation, these measures might not be valid. All right. So the diastolic dysfunction for the RV is relatively simple. It is not as complicated as the LV. So we talk about impaired relaxation of the right ventricle. So just like the left ventricle, the right ventricle gonna relax and fill with blood. Okay. So the first sign of RV diastolic dysfunction is the inability of the RV to relax. And if the E over A is less than zero point 0.8, it suggests that there's impaired relaxation. Okay? So remember, when you look at the tricuspid inflow, you're going to have, just like the mitral valve, you're going to have your E velocity and your A velocity. Remember, the E velocity is when the tricuspid valve open and blood is sucked in from the right atrium into the right ventricle, you get your E velocity. And then at the end of diastole, the atrium contracts and has an additional amount of blood to the RV. So you get your E and your A velocity. So if the E over the A, so you have to measure these velocities. This is done with pulse wave. And if the E to A ratio is less than point 0.8, it suggests impaired relaxation. Okay? Now, pseudonormal. Pseudonormal, remember, our pseudonormal on the left side was our type 2 diastolic dysfunction, right? On the left side, we talk about a type 1 or type 1 diastolic dysfunction on the left side when the E is smaller than the A. Okay, so the E to A ratio is less than 1. Uh, we're not going to go into that, but the E to A ratio is less than 1. And then pseudo-normal, it looks normal, but it's not normal. When you look at your E prime, the E prime is less than 8 centimeters per second. On the right side, pseudo-normal is defined by your E to A ratio between 0.8 and 2.1. Okay, so for abnormal relaxation, that E to A is less than 0.8. Okay, for pseudo-normal, the E to A ratio is between 0.8 and 2.1, but the E to E prime ratio is greater than 6. Okay, and then when you look at your, you have what we call diastolic predominance in the hepatic vein. Remember, in the hepatic vein, you're going to have a systolic component and a diastolic component. When we say diastolic predominance, that means the diastolic component is larger than the systolic component. So, so, so this is our pseudonormal filling on in the RV. The E to A ratio is between 0.8 and 2.1, and the E to E prime ratio uh, is greater than 6. Then you have diastolic predominance in the hepatic vein. So that's pseudonormal. Remember, impaired relaxation, your E to A is less than 0.8. Then we have restrictive filling. So this is a worse stage in diastolic dysfunction. When you have restrictive filling on the right side, the E to A ratio is greater than 2.1. Remember, on the left side, if it's greater than 2. So on the right side, if the E to A ratio is greater than 2.1, and if your deceleration time is less than 120 milliseconds, then that's restrictive filling. Okay? So diastolic dysfunction on the right side, we just have three stages. Impaired relaxation, the E to A is less than 0.8. Pseudo-normal, if the E to A is 0.8 to 2.1, and your E prime ratio greater than 6, and you have diastolic predominance in the hepatic vein. And remember, we said diastolic predominance, it does mean, when you do the Doppler in the hepatic vein, you have a systolic component, a diastolic component, an atrial reversal. It just means that the diastolic component is greater than the systolic component. So that's diastolic dysfunction in the RV. Now remember the right ventricle, the blood supply to the right ventricle, the blood supply to the right ventricle is via the right coronary artery, and it's the acute marginal branch of the right coronary artery. Okay, so the blood supply to the right ventricle is via the RCA. Okay, that is via the right coronary artery, the acute marginal branch. The moderator band is supplied by the first septal perforating branch of the LAD, and that's important. well, not so much for the technicians, but for the doctors who are doing the course. You need to know because remember what we're saying is that the RVC, the right ventricle is supplied by the right coronary artery. But this portion of the right ventricle, the moderator band, is supplied by a branch of the left anterior descending coronary artery. Okay? So the moderator band, and this is a fair question in the exams for the doctors. The moderator band is supplied by the first septal perforator band, a first septal perforating artery, a branch of the left anterior descending coronary artery. Okay, so let's look at the right side of the heart in a little bit more detail. The right atrium has three main functions. It functions as a reservoir that basically it's storing blood. So when the tricuspid valve is closed, it's just filling up with blood. That's the function. It fills up with blood. It functions as a reservoir. And then when the tricuspid valve opens, it functions as a passive conduit. So it allows blood to flow from the IVC, the superior vena cava, through the right atrium and into the right ventricle. So it acts as a passive conduit. And then the third function of the right atrium is an active conduit late in diastole. Remember when the atrium contracts and it forces blood across the tricuspid valve into the right ventricle. So you can say that the and also the left atrium. So the right atrium as a reservoir function, stores blood, and then it has a passive conduit, just allow blood to flow from the IVC, the SVC, that's the inferior vena cava, the superior vena cava, across the tricuspid valve into the right ventricle. And then it has an active conduit phase where when it contracts to force blood into the RV. So those are the main function of the right atrium. Remember, I showed you how to trace the right atrial area, um, and it should be a routine part of your study. The right atrial area. Normal right atrial area is less than 18 centimeters per second, and this is done in end systole, just like the left atrium. It is done in end systole. So the right atrial area is should be less than 18 centimeters, less than 18 centimeters squared. The left atrium, however, we use a volume index. So if you evaluate in the left atrium, it should be a volume, and we use a volume index. And remember, when we index something, we divide it by the body surface area. And then when we outline the right atrium, remember the major axis or the major dimension and the minor dimension. The major dimension should be less than 5.3 centimeter. The major dimension, remember, is from the tricuspid annular plane, right at the center of the tricuspid annular plane, down to the bottom of the right atrium, and that should be less than 5.3 centimeters. And then the minor dimension is straight across, so it's perpendicular to the major dimension in the mid segment. And uh, you can memorize these figures. However, the most important figure to memorize here is the right atrial area, which should be less than 18 centimeters squared. Okay, it is done in end systole, ventricular systole, just like the left atrium. Um, the right atrial pressure, it is crucial that you guys remember how to evaluate right atrial pressure, because in order to get the RV systolic pressure or the pulmonary artery systolic pressure, you have to add the right atrial pressure to your tricuspid gradient. And to evaluate the right atrial pressure, you have to look at the IVC diameter and its collapsibility in inspiration. Remember, the normal IVC should be much less than 2.1 centimeters. It's supposed to collapse more than 50% in inspiration. Okay? However, it should not be used if the patient is on the ventilator. And it should be measured, when you're measuring your IVC, the diameter, it should be measured in end expiration. So remember, the patient is breathing in. When you breathe in, that's inspiration. When you breathe out, that's expiration. At the end of the expiration, you tell the patient to hold the breath. So, and you do your measurements. Another important point, the IVC might be dilated in young athletes. So bear that in mind. And hepatic, remember you look at the hepatic vein. You have to get your hepatic vein. If the RA pressure is elevated, then you might have what we call diastolic predominance. So let's go over the use of the IVC to determine right atrial pressure. If the IVC is less than 2.1 centimeters, and if you have more than 50% collapsibility with inspiration, then the right atrial pressure is 3 millimeters mercury. If the IVC is greater than 2.1 centimeters, and you have less than 50% collapse with inspiration, the right atrial pressure is 15 millimeters mercury or more. Anything that falls in between those two extremes, we give the right atrial pressure 8 millimeters mercury. So the numbers you have to memorize is 3, 8, and 15. 3, 8, and 15. 3 if it's normal. Normal, the IVC is less than 2.1 centimeter. You get more than 50% collapsibility with inspiration. Then if it's abnormal, very abnormal, then it's 2.1 or more end expiration. You're going to measure it. So the diameter of the IVC is 2.1 centimeter or more. You get less than 50% collapsibility with inspiration. And the right atrial pressure in that situation is 15 millimeters mercury or more. You'll have to memorize those numbers. 3, 8, and 15. 3, 8, and 15. All right. So, I'm just going to, you don't have to memorize that. If you guys understand this, that's fine. This is more for the doctors who are doing the course. We'll look at something you call the hepatic vein systolic filling fraction. And all it is when you do your hepatic vein Doppler, it is the systolic velocity divided by the systolic plus diastolic velocity. So whatever measurement you get for the systolic velocity, you put it in the top. At the bottom, you're going to add the diastolic and the systolic velocity. And that's called the hepatic vein systolic filling fraction. If it's less than minus 55%, if it's less than 55%, it's most sensitive and specific for elevated RA pressure. You don't have to memorize that. It's rarely done. What we look at is the IVC. But if you want to do something more, you can do your hepatic vein systolic filling fraction. And if it's less than 55%, then it suggests elevated RA pressure. Another thing, when the pressure in the right atrium is high, it's going to be dilated. It just, if there's a lot of pressure in the right atrium, it's going to be dilated. So if the right atrial pressure is extreme, it's going to be big. And not only big, but you get interatrial septal bulging into the left atrium throughout cardiac cycle. So these are some additional things that you can look for. The most important, however, is the dilated right atrium. and the bulging of the interatrial septum into the left atrium throughout cardiac cycle. But what you have to remember for elevated right atrial pressure is the IVC, inferior vena cava. Okay, you remember you measure it just proximal to the hepatic vein. You have to memorize the diameter. The magic number there is 2.1, and you're looking for more than 50% collapsibility with inspiration, which suggests that the right atrial pressure is normal. So normal right atrial pressure, the IVC will be less than 2.1 centimeters. You get more than 50% inspiratory collapse, and the right atrial pressure in that situation is 3 millimeters mercury. If it's more than 2.1 or more, 2.1 or more, like 2.1 centimeters or more, and you have less than 50% collapsibility with inspiration, then you had 15 millimeters mercury, and then the right atrium in that situation would be large. The best way to do it, and then you guys should have your instructors show you how to do this. The best way to do it is to put your cursor across the IVC and use your M mode to outline the IVC, and you can clearly see the collapsibility with inspiration, and then you can measure it. So ask your instructors to show you how to do this. So you first do your subcostal view, you outline the IVC, you put your cursor there, and then you press the M mode button, and you can see the IVC in its a good length of the IVC, and you can look at inspiratory collapse. RV thickness. We briefly went over this in some of our reading session. But one of the best way to look at RV thickness is your subcostal view. You can also look at it in the parasternal long axis view. RV thickness is very, very important. And if you can pick this up, it will tell you a number of things. One is if it's thick, we talk about RV pressure overload. So if the pressure is tremendous in the RV, over time the wall of the RV will be thickened. And when we say thicken, we talk about an RV dimension greater than 5 millimeters or 0.5 centimeters. So the RV is thick if when you measure it, if it's more than 5 millimeters or 0.5 centimeters. And remember, when you do your measurement, you have to zoom it to decrease the error. All right, so zoom it. The RV wall thickness can also be seen in infiltrative processes. And what we mean by that is if something gets into the muscle, common, well, not really common, but one of the infiltrative processes is something we call amyloidosis, or glycogen storage disease. So these are just, some conditions that will give you RV thickening. Also, cardiomyopathy, hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy means, hypertrophic means it thickened. Cardiomyopathy means it's an abnormality of the heart muscle. So if you have hypertrophic cardiomyopathy, thickening of the heart muscle, you can see that in the RV. And when you measure it, it will be more than 0.5 centimeters or 5 millimeters. So the views that you're going to look for is the subcostal view or the left parasternal long axis view. But the subcostal view is probably the best. And then you zoom it. Remember, you have to zoom it. When you zoom it, you decrease the error. All right. So, and you measure it in end diastole. Remember, when you measure in the LV, When we measure the LV, we measure it in endostally. Remember, when you measure the thickness of the septum and the posterior wall, it's in endostally. Same thing for the right side. So when you're measuring the RV wall thickness, it should be measured in endostally. We use fundamental. You should use fundamental imaging as opposed to harmonic. And when we do ultrasound physics, you will understand the difference. But harmonic imaging tend to give the impression that it gives a more thickening appearance of structures. So harmonic imaging gives an impression that the structure is thickened. So when you're doing these measurements, you should probably use fundamental imaging. So don't worry about it. We will go over this in ultrasound physics. Um, and RV wall thickness, it's thickened if it's more than 0.5 centimeters or 5 millimeters. Also, you can see thinning. So the RV wall may be thickened, it may also be thin. And you get RV wall thinning um, in arrhythmogenic RV cardiomyopathy. So this is the most common reason, well, one of the most common reasons for RV wall thinning. And what is meant by arrhythmogenic RV cardiomyopathy? So the heart is a muscular pump. It is composed mainly of muscles which contracts and pump blood throughout the body. In arrhythmogenic RV cardiomyopathy, what happened? The muscle is replaced by fatty tissue. So when you're measuring muscle, you're not going to see much muscle. Fat does not contract, so that's a big problem. So if the R if the RV wall or the muscle is replaced by fat, then that's tremendous amount of problem. And we have a separate section for cardiomyopathy, and we'll go over that in a little bit more detail. But arrhythmogenic RV cardiomyopathy, arrhythmogenic just means abnormal rhythm. So if you don't have normal muscle, it's going to be very irritable. And these patients tend to get what we call ventricular tachycardia. They can also get ventricular fibrillation and they die. Okay? So RV cardiomyopathy means the right ventricular muscle disease. So the muscle is replaced by fatty tissue. Um, okay, so the RV linear dimensions. So I think we went over this briefly, but if you measure the linear dimensions in the RV, you can determine if it's dilated, yes or no. And the RV may be dilated because of volume or pressure or RV failure. An example of volume overload is if you have a defect. Say for instance, you have a ventricular septal defect. You have a hole in the interventricular septum. Blood flows from the left ventricle across this defect into the right ventricle because the pressure in the left ventricle is greater than the pressure in the right ventricle. So blood is going to flow across that opening into the right ventricle, cause it to be dilated because of too much blood. So that's what we call a volume overload. And the same thing occurs if you have an atrial septal defect. Increased blood flow on the right side cause the right ventricle to dilate. And pressure overload scenario is if there's obstruction to blood getting out of the right ventricle. So if you have right ventricular outflow tract obstruction, anything of that nature can increase the pressure and cause the RV to dilate. It will thicken as well, and then it will dilate. And then RV failure, um, if you have a heart attack, which involves the right ventricular muscle, weaken the muscle because the muscle is weak, it tends to dilate. So, you can get right ventricular dilatation in those scenarios. Uh, The RV, when you just look at your four-chamber view, it's important to, that's why I say it's important to look at normal studies. So you pick up what's normal. In a normal individual, the RV should appear smaller than the LV. In a normal individual, the RV should appear smaller than the LV in the apical four-chamber view. So get accustomed to looking at normal studies so you know what's normal. It should not be more than 2/3 the size of the LV. And when we evaluate in the right side, we do what we call the RV focus view. It's an apical four-chamber view, but with a little modification to look more at the RV. So it's called the RV focus view. And remember when we do the RV minor dimension, that's right at the RV base, we use the tricuspid annular plane. That should be less than 4.2 centimeters. Get in the habit when you're doing your routine study to do these measurements. And you can also do the RV mid cavity, and that should be less than 3.5 centimeters. So it should be an RV focus view. It's like your apical four-chamber view with a little bit more manipulation to get more of the RV. The RV basal area is the tricuspid annular plane, and you do your measurements. It should be less than 4.2 centimeters. And when you do your RV mid cavity measurements, uh, it should be less than 3.5 centimeters. The RV longitudinal dimension, again, it is from the RV apex to the tricuspid annular plane, the plane of the tricuspid annulus. I think I showed you guys that in our reading session. In that case that the example I showed you, it was not done properly because it was not at the plane of the tricuspid annulus. It was not at the tricuspid annular plane. But the measurement should be from the apex of the RV to the plane of the tricuspid annulus, and that should be less than 8 centimeters. All right, we did a little bit of this as well. The right ventricular flow tract. So these are all measurements to determine the size of the right ventricle, the size of the right ventricle. So we use the right ventricular flow tract. And the view you're going to look at is the parasternal long axis view and the subcostal view. Again, it's measured in end diastole. And if you remember, when we look at the proximal RVOT in our parasternal long axis view, where our RV outflow tract is on top, the proximal should be less than 3.3 centimeters or 33 millimeters. So remember when you're doing your measurement of your LV in diastole and you do your septum, the LV cavity size in diastole and the posterior wall, if you just extend up a little bit more, then that's the proximal RVOT, and that should be less than 3.3 centimeters or 33 millimeters. It's important because it's going to be dilated in arrhythmogenic RV cardiomyopathy. And remember, we went over that a little bit. Now, for the if you use the short axis, so the distal RVOT is when we do our short axis view at the level of the aorta, and just right where you have the pulmonic valve, that should be less than 27 millimeters or 2.7 centimeters. If that's more than 27 millimeters or 2.7 centimeters, then it's dilated. So you have to be clear where you're measuring and you have to document what you're measuring. I read, well, I didn't, I looked at a report last week, not I looked at a report last week and they gave me they gave a RV measurement of, I think, 4.1. I don't know where to measure. You have to say what this measurement, because if it's at the base of the in the apical four chamber view or the RV focus view, and it's at the base, that's normal because it's dilated if it's greater than 4.2. If it's at the mid level, then it's abnormal. If it's the proximal RVOT, then it's also abnormal. So you have to say exactly what the measurement you're putting down is. You can't just say the RV is whatever. So remember the proximal, if you do your parasternal long axis view, uh, when you do your measurements of your LV, above that is the proximal uh, that's your proximal RVOT measurement, and that should be less than 33 millimeters. And the distal, you have to get your short axis view at the level of the aorta, and then it's where you have the pulmonic valves. If that's more than 27 millimeters, then that's dilated. Say what you're measuring. Okay. We also went over the fractional area change, but this is when we're looking at systolic function. Remember, when we look at the fractional area change, is basically the how much the area change from diastole to systole. So this is done by looking at the end diastolic area. So again, RV focus view, four chamber view with a focus on the RV, and you get your end diastolic area. You're going to subtract from that the end systolic area. You're going to divide that by the end diastolic area times 100. It should be more than 35%. It should be more than 35%. And it correlates, the fractional area change correlates very well with RV ejection fraction by MRI. So you have to know how it's measured, okay? You have to know how it's measured. So it's a fractional area change. Very important. Fractional area change, RV focus view, apical four chamber view. You get your end diastolic area. You're going to subtract from that the end systolic area divided by the end diastolic area times 100. It should be more than 35%. Okay. RV volumes. For those of you who are doing an exam, Greg, if they put anything about volume and they put 3D echo, that's the way to go. Anything in echo, if they put 3D echo, that is the gold standard. 3D echo allow volume assessment, very, very accurate in the heart. And they use a disc summation method or apical rotational method. You don't have to know about the method, but 3D echo, three-dimensional echo, give you volume assessment in the heart, very, very accurate. And if you use your 3D echo, if the volume, the right ventricular end diastolic volume should be 89 mLs per meter squared. So it's index. You can see that it's index. It's divided by the body surface area. So the normal is about 89 mLs per meter squared, and then the RV end systolic volume is about 45 mLs per meter squared. It is about 10 to 15% lower in women. And the normal ejection fraction using the 3D volume assessment is greater than 44%. So normal EF is on the right ventricle is greater than 44%, not the right side. The right side, sorry, not the left side. The left side normal EF is about 55 to 70%, whereas for the right ventricle normal EF is about 44% or more. a couple important points. Uh, Looking at the RV and the interventricular septal morphology. So it's important to just look at the heart. So when you're doing your echo, don't just start doing stuff. Look at the heart. Look at the heart. Because by just looking at the heart, you can glean a lot of things and it can sort of tell you where to focus your attention. For RV, volume overload. So if the right ventricle is volume overloaded, just looking at the RV, you can determine that. Because the if there's volume overload uh, in the RV, then the LV assumes what we call a D shape. And the LV assumes the D shape because the increased volume pushed the septum towards the left. And then so that becomes a straight line, okay? And then you have bulge, the LV bulge on the lateral side. So it assumes a D. It looks like a D shape. And you can see that in either the apical four-chamber view or the short axis. So if you look at the short axis, this interventricular septum will be pushed towards the left, giving a sort of straight line. And then, of course, you have that curvature at the bottom. So the LV looks like a D. So it assumes a D shape with volume overload. And I say because the septum flattens, give it a sort of straight line appearance. And this is evident in diastole. So it is evident in diastole. So the RV volume overload, uh, if you look at it in diastole, so RV volume overload uh, during diastolic assessment will assume a D shape because of flattening of the septum. But you can have RV pressure overload, and the LV also assumes a D shape. The LV also assumes a D shape with volume overload, but this is during systole. And for the same reason, the septum flattens, but this is in systole. Okay, so this was RV pressure overload. So with RV volume overload, the LV assumes a D shape in diastole, and with pressure overload, the LV assumes a D shape in systole. Um, in it's this question frequently appears on physician boards. It's fair game for technician boards as well. So if you could, if you try to understand that. So you have volume overload, too much volume on the right side, and then pressure overload if there is increased pressure. So you get a D shape uh, LV in both scenarios, but with the volume overload, the D shape is in diastole, and with pressure overload, the D shape is in systole. And then we have something we call the eccentricity index. So if you measure in the short axis view, say you use the mid cavity level short axis. If we measure anterior to posterior and septal to lateral, that should be that dimension. So the anterior posterior measurement over the septal to lateral measurement should be approximately 1 because it's spherical. So the heart is sort of spherical in the short axis. So the dimension from the anterior to the posterior to the septum to lateral should be approximately 1. However, in RV volume overload, then your eccentricity index will be more than 1. So the anterior posterior divided by the septal to lateral dimension usually more than 1. Uh, you know, we don't commonly do this measurement, but that's the eccentricity index. So you're just measuring the diameter from the anterior to the posterior, and you measure the dimension from the septum to the lateral. That ratio should be 1. So they should be the same. They should be same dimension. So when you put one over the other, you get 1. But with RV volume overload, okay, with RV volume overload, and the reason why it's less than 1, because remember we said with volume overload, the septum flattens, so it's gonna the septum to lateral dimension is gonna be less. Remember? The septum to lateral dimension is going to be less because the increased volume in the right ventricle is going to push the septum more towards the lateral side, decreasing that septal to lateral dimension. So that ratio is going to be more than 1. Um, so RV volume overload, you get the D shape in diastole. RV pressure overload, you get that D shape in the LV in systole. Um, Hemodynamic assessment of the RV and pulmonary circulation. Um, the systolic pulmonary artery pressure, we use a tricuspid regurg velocity, and we went over this numerous times. You look at the gradient. So the only reason why you get tricuspid regurgitation is because there is a gradient from the RV to the RA. The pressure in the RV is greater than the pressure in the RA. So if that tricuspid valve is incompetent, you're going to have blood flowing from the RV to the RA in systole, because that's when the RV contracts. So that gradient, which is the RV systolic pressure minus the RA pressure, is equal to 4V squared, modified Bernoulli equation. V is the velocity of that tricuspid regurgitation. So if you square the velocity and multiply it by 4, you get the gradient. To get your pulmonary artery systolic pressure, your systolic pulmonary artery pressure, you just have the right atrial pressure. But you need to have tricuspid regurgitation. Fortunately, in 80 to 90% of a normal individual, there's some amount of tricuspid regurgitation. So you can almost always get your systolic pulmonary artery pressure. We also went over the end diastolic, the pulmonary artery diastolic pressure. Remember, pulmonary artery diastolic pressure. So the pulmonary artery has a systolic pressure, it has a diastolic pressure, just like your normal blood pressure. The pulmonary artery diastolic pressure, you need to have PI, you need to have pulmonic insufficiency, and you use your end diastolic velocity. So end diastolic velocities, remember you have an early diastolic velocity and you have an end diastolic velocity. To get that pulmonary artery diastolic pressure, you use your 4V squared, modified Bernoulli equation, 4V squared to get the gradient. And the velocity that we're using here is the end diastolic PI velocity. The end diastolic PI velocity. We squared it. We're going to square it. But you have to have the right atrial pressure. And we went over how to determine right atrial pressure. The mean PA pressure now. So some of you guys who are doing studies, I know you have been doing your pulmonary artery acceleration time. But do you know why you do your pulmonary artery acceleration time? You do your pulmonary artery acceleration time because it enables you to get the mean PA pressure. The mean PA pressure is more meaningful than your pulmonary artery systolic pressure or your pulmonary artery diastolic pressure. The mean PA pressure, and the classic definition of pulmonary hypertension is the PA mean pressure greater than 25 millimeters of mercury. So to get the mean PA pressure, you can use your PA acceleration time, or you can use your systolic and diastolic PA pressure. And when I did the registry exam, there was something about PA acceleration time. So we'll go over that in a little detail. Okay. So so as we mentioned before, well, for the same, remember your right ventricular systolic pressure and your pulmonary artery systolic pressure is the same thing. There's the same numerical value, except if there's right ventricular flow tract obstruction. So your right ventricular systolic pressure is the same as your pulmonary artery systolic pressure, unless there's right ventricular flow obstruction. To get your right ventricular systolic pressure and your pulmonary artery systolic pressure, you need to have tricuspid regurgitation. And we went over the pathophysiology of TR. You should look at your TR signals in multiple windows, because remember, you want to get the beam as parallel to blood flow as possible. Remember our angle theta? If theta is 0, then the cosine of 0 is 1. If theta is 90, cosine of 90 is 0. So you want to get your beam as parallel to blood flow as possible. You want to get your theta as close to 0 as possible. And you use your sweep speed of 100 millimeters per second. So you want to broaden it out to decrease your errors. And the normal mean PA pressure is 25 millimeters or less. Okay, 25 millimeters or less. And we talk about systolic pulmonary artery pressure when we if we're going to use the systolic pulmonary artery pressure to determine hypertension, pulmonary hypertension, the current recommendation is the systolic pressure between 35 or 36 millimeters mercury, but the mean PA pressure 25 millimeters mercury or more. So current definition for pulmonary hypertension, mean PA pressure 25 millimeters mercury or more, or the systolic pressure 35 to 36. The American College of Cardiology and the American Heart Association recommend further evaluation for patients who present with shortness of breath and a right ventricular systolic pressure greater than 40. So you have to do additional evaluation of these patients. All right, so we've been talking about the mean PA pressure. How do we determine mean PA pressure? Because I've been telling you guys this is the gold standard. A mean PA pressure of 25 greater than 25 millimeters mercury suggests pulmonary hypertension. So you can get your mean PA pressure by using 2/3 of the diastolic pressure and add to that 1/3 of the systolic pressure. So if you determine your pulmonary artery systolic pressure by using your TR jet, and then the diastolic pressure by using the PI jet, you can get the mean PA pressure by getting 2/3 of the diastolic pressure and adding to that 1/3 of the systolic pressure. So the mean PA pressure is 2/3 the diastolic pressure plus 1/3 the systolic pressure, and you'll get the mean PA pressure. Remember, we're talking about the acceleration time. The acceleration time is used in this equation to get the mean PA pressure. You use 79 minus 0.45 times the acceleration time. And this is valuable. This can be used if the acceleration time is less than 120 milliseconds. So if the acceleration time is less than 120 milliseconds, you can use just the acceleration time to get the mean PA pressure. So it is 79, Greg, 79 minus 0.45 times the acceleration time. If the acceleration time is sorry, no, so sorry about that. So that's for acceleration time up to 120. If the acceleration time is less than 120, then you use the 90 minus 0.62 times acceleration time. So so the acceleration time greater than 120 milliseconds, you use the top equation, that's 79 minus 0.45 times the acceleration time. And then if the acceleration time is less than 120 milliseconds, then use the 90 minus 0.62 times the acceleration time. Okay? The important thing here, then they probably don't ask you to use the equation, but you have to know that it is some value times the acceleration time. You're going to subtract that from whatever. So if the acceleration time is large, then you're gonna subtract a large number from the value. So it's going to make the mean PA pressure less. Okay? If the acceleration time is a small number, then you're going to subtract a small number. So it mean PA pressure is going to be higher. So they probably don't want you to remember the equation, but they will say if the acceleration time increases, what's going to happen to your PA pressure? That's the question they'll ask you. Or you can determine the mean PA pressure by using the early PI velocity. Remember the PI, when we have PI, you have an early velocity and an end or a late velocity. So 4 times the early velocity squared plus right atrial pressure will give you the mean PA pressure. All right, so the methods that you need, you should remember, however, is the 2/3 diastolic pressure plus 1/3 systolic pressure. And remember that you're going to multiply some number times the acceleration time and subtract it from whatever. You don't have to remember that. Memorize that equation. You also have to remember that you can use the early PI velocity, square that, multiply it by 4, and then add the right atrial pressure, and you get the mean PA pressure. Don't worry about the using the VTI method. Don't worry about that. All right. Um, you know, we talk about vascular resistance. That's just the resistance to flow. So when we talk about any type of vascular resistance, there's a resistance to the blood flowing, and that, that definition is uh, the uh, the pressure that the system generates is equal to the flow in the system times the resistance. So the resistance is equal to the pressure change divided by the flow. And you don't have to, just remember that there's a resistance to blood flow. And that resistance to blood flow depends on the pressure difference in the system divided by the flow. Um, I, I, you know, for the fellows, I expect them to understand this and know what it means. For the technicians, you don't have to understand this. Just know that there's a resistance to blood flow, and it's related to the pressure difference in the system divided by the flow. Um, a, During exercise, the pulmonary artery pressure during exercise usually it goes up a little bit, but it should be less than 43 millimeters mercury. If your PA pressure increase more than that with exercise, then it suggests that you have a problem. And a lot of these patients usually present with exercise shortness of breath. Um, However, well-trained athletes or older individuals can sustain pulmonary pressures 55 to 60 millimeters mercury with exercise. Um, so um, remember when we were doing LV systolic function, we talk about the heart. We describe the motion of the heart in detail. So the heart have multiple motion. Remember, it has this ringing motion. It has a ringing motion. So it sort of torques. The base of the heart moves in a clockwise fashion, and the apex of the heart moves in an anti-clockwise fashion. So it torques. And not only that it torques, but it contracts, the base moves up, right? And not only the base moves up, but the heart thickens during contraction. Um, the RV does have a similar type of motion as well. Uh, the base to the apex shortens um, when the RV empty, and we talk about the base to apex shortening greater, which provides which have a greater role in the RV emptying than the LV emptying. So the base of the heart, or the tricuspid annular plane, moves up towards the apex. It shortens, and it also torques, as we discussed in the case of the LV. Um, There are other methods that we can use to evaluate global RV function. So when you talk about RV function, it has a systolic function, okay, when it contracts and push blood out, and then it have a diastolic function which relaxes, fills with blood. But you can talk about the overall function of the RV. And if you guys remember the myocardial performance index, MPI, or myocardial performance index. Um, and then we talk about RV dP over dt, that change in pressure with time. Uh, we talk a little bit about RV ejection fraction, fractional shortening. Um, let's all right, so I'm not going to do strain and strain rate. We'll leave that for the next session. And so we'll finish up that, because that's a new concept for you guys. And I don't want to introduce a new concept at this time. But RV strain and strain rate, and we will probably, I think we did discuss a little bit about LV strain and strain rate, so we can go over that. Um, But we're gonna wrap up right here. Any questions? Remember, I can't hear you guys, so you have to type your questions. Any questions? Can't hear you guys, so you have to type your questions. Or if you want to call in your questions, that's also another option. All right. Uh, no question. All right. So we're gonna stop here, and we still have some more RV uh, right-sided heart to do. Not much, but the strain and strain rate uh, is a new concept, so it might take a little time for you guys to understand that, and then we will touch on M mode. Uh, so I think the exam in June will is going to include the right heart and M mode. Um, so so that's it. Okay. Can you repeat that? Okay, can you repeat that question? It flashed and then went off. Okay, so when we okay, let me go back to that slide. All right, so the question was, I think, using the using the acceleration time, to determine the mean PA pressure. So if the acceleration time is more than 120, then the formula you're going to use for the mean PA pressure is 79 minus 0.45 times the acceleration time. Okay, so I think the question relates to the acceleration time. So if the acceleration time is more than 120 milliseconds, this is the formula you're going to use. 79 minus 0.45 times the acceleration time. So the acceleration time is basically the time the blood takes to move from rest to peak velocity. The time it takes from rest to peak velocity. So when you do your envelope, your Doppler envelope is from the initial envelope to the peak. And remember to ask your instructors to show you how this is done. So if the acceleration time is more than 120 milliseconds, 79 minus 0.45 times the acceleration time. If the acceleration time is less than 120 milliseconds, it's 90 minus 0.62 times the acceleration time. The important thing is not to memorize the formula. Remember, it's the acceleration time times the number subtracted from something. So if the acceleration time is a large number, so if you have increased acceleration time, you're going to subtract a large number from the number. So it's going to be, the mean PA pressure is going to be small. If the acceleration time is a very tiny number, then you're going to subtract a small number from that number. So the mean PA pressure is going to be elevated. So with a very rapid acceleration time, the mean PA pressure is going to be high. So that's an important point there. If there are no more questions, we're going to wrap up here. Okay. Okay, and then see you guys on Thursday. Bye bye.